sec. All right. So this is acute leukemia, our chapter on acute lymphoblastic leukemia. Okay. So in a previous discussion, we discussed the difference between acute myelogenous leukemia and acute lymphoblastic leukemia. We discussed what stain we can use in the laboratory. That's TDT. Okay, TDT would be positive for ALL, and it would be negative for AML. All right, cool, peachy. Everybody knows that already. Now let's begin. We can use another cytochemical stain, which is your periodic acid shift, which would test positive for ALL as well. Okay, but the most important one that you can use is periodic acid shift, TDT. All right, what do we mean by TDT? TDT is known as your terminal deoxynucleotidyl transferase, deoxynucleotidyl transferase, and this is how it looks like in the cell in the microscope. It's blue actually, and the ones that are positive for the blast cells that are positive for TDT is actually colored brown, indicated by these ones. Wait, let me use my laser pointer. This is your these are your TDT positive cells. So notice that when you count this, there is more than 10. So that would be enough for us to diagnose, enough for, not for us, but for pathologists to diagnose um, acute lymphocytic leukemia. All right? Okay. Now let's move on with the World Health Classification of how does the World Health Classification classify this type of leukemia? Well, as I previously, when I was still a student, the only classification that we had when I was studying was FAB, the French, American, and British classification. And now World Health came in and they actually made everything easier for us to study. And this is based on the maturation of T cells and B cells. And in this particular discussion, we're going to talk about it on the pre-B cell and early T cell stages. All right. So a pre-T or B cell leukemia, and it's usually based on the CD markers. All right. So the American type doesn't have the French the FAB type doesn't have that one. It relies on morphological and the age distribution. Okay? But for World Health, it's much more easier for us to remember because of the CD markers and the chromosomal translocations. That's the reason why earlier chromosomal studies and immunophenotyping has been the norm in the diagnosis of um, acute leukemias or leukemias in general. All right. So all what call this pre B ALL, that means that the abnormality is the B cells, okay, the pre-B cells, have an abnormality in the chromosomes, specifically in the specifically in trisomy 21. The abnormality is trisomy 21. Does anybody know what disorder or what genetic disorder people with trisomy 21 have? In the chat box. Anybody knows? What's the abnormality in patients with trisomy 21? Cytogenetics. You guys already took up cytogenetics, right? Down syndrome. Very good. Down syndrome. All right. So Down syndrome is for trisomy 21. What are the CD markers present on patients with pre-B cell ALL? Well, you have 10, 19, and 20. How do I remember this, sir? Um, I'm not very sure, but these are your what we call kit ligand molecules. Okay, these are known as your kit ligand molecules. And for me to remember this is that there's 10 and 20 pieces of samples in my kit. And when I minus 1, there's 19. There's also 19. There's one in my then when there's 19. That's my mnemonic. I don't know if it's useful, but this is the most important thing that you need to remember. It's part of the kit ligand. Okay, KIT ligand. Okay, so it's part of the kit ligand. So that for me is the easiest way for me to remember. It's 10 and 20 minus 1. I use this one. I changed this one in I changed I as to 1 because there's a T is a translocation. Trisomy rather. Trisomy 21. All right? So for me that is the way. That's a way for me to not forget about this one and make a neural connection. I'm not sure if it's useful for you guys, but hopefully you understand my mnemonics. All right, CD10 is also known as your Kala antigen. What do we mean by Kala? Common ALL antigen. Kala antigen. Um, Usually when you see this in the laboratory, especially there in the Philippines, it's a send out, and there's only several hospitals that does it in Manila. It's either St. Luke's or the UST hospital. Okay, and it's very expensive actually. I think the last time I sent it in the Philippines was way back in 2011 before I left for another country. It's around 25,000 to measure the Kala antigen because it's flow cytometry. It's done through flow cytometry. Okay, so that's CD10. Common translocations in pre-B cell leukemia. So we have 822 and 12 1221. 922, sorry, 922. A 922 is a bad prognosis. If these CD markers are present, it's a bad prognosis. If this mirrored one, I call it the mirror translocation. Why is it mirrored? Basically, when 21 looks in the mirror, when 12 or 21 looks in the mirror, they see their opposite self. So this is called also as the mirror translocation. And if you have a mirror translocation, the prognosis is good. Okay? Is this important? Not sure, but you just need to remember that it's for pre cell leukemia, pre B cell leukemia. All right. Now, classification. What are the common translocations identified by B cell ALL? There is three. Okay, but the most common one is note that it's the most common one is the most common chromosome affected is chromosome 8. See, the most common one affected is chromosome 8. Why? T40, T814, 822, and 2 and 8. See, 8 is affected in B cell. All right, B cell ALL. The first one that we talked about, the one with two translocations, 922, and the mirror translocation of 12, that's for pre-B cell. Right? There's a difference, guys. Please don't forget the difference. B cell. So I think in a certain way we got an easier way to diagnose pre B cell, but for examination purposes, it's another set of numbers that you guys have to memorize. All right. Which chromosomal translocation is associated with Burkitt's lymphoma? It's T814 or translocation 814. All right. So this one is associated with Burkitt's lymphoma or Burkitt's leukemia. Can I use them? Can I use this Burkitt's lymphoma? Can I use it in interchangeably? Actually, yes, because they can overlap each other, and eventually someone with Burkitt's leukemia will develop Burkitt's lymphoma if left untreated. Okay? CD markers that differentiate T cell ALL from other forms of leukemia. There is actually a mnemonic for that one. It's easy. 328. And the most important one is 3. Please remember this one. Okay? CD markers that differentiate T cell ALL from other forms of leukemia as identified by the World Health Organization is CD328. So you don't need to remember everything. How do I remember this? Sir, there is CD4 and CD8. These are markers for your helper T cell. This is a marker for your cytotoxic T cell. Okay? Cytotoxic T cell. So please don't forget that one. What about 5, 6, and 7? So just remember 4 and 8 so that you can remember, I just need to remember that it's until 8. See? Mnemonics. We have to be smart. um, we have a saying in the board exam review, daig ng wais ang matalino. Alright? Because si Matalino, he will just study everything, every material, and he might lose a lot of time and focus on remembering everything, while the wise person will just follow the mnemonics and memorize them as easy as possible so that he may pass. Okay, patients with T cell ALL usually have what unusual physical examination findings. They have what you call a mass in the mediastinum. Why is there a mass in the mediastinum? Where is your mediastinum located ba? I asked this last week already. I don't know if you guys remember, but I asked this, I think, from Ella, or I think Earl. Earl, do you remember where's your mediastinum? Earl. Yeah, I remember na, kaya nauso yung wag mo akong dinadaan sa pogi-pogi, Earl. Where is your mediastinum? Oo, yes, yes, yes. Saan na siya ngayon? Saan ang iyong mediastinum? Where is your mediastinum? You corrected it before. Yes, very good. Thank you. So your mediastinum is in your chest, and patients who have T cell ALL have this particular physical examination feature, a mass in their mediastinum. Why? What's in their mediastinum ba? What's in the mediastinum that is important for T cells? What organ are we talking about here? Um, let's look for people in the chat box. Somebody. Yes! Oh, girl, I love it. Hindi pa ako nakapag-start magtingin, but you already answered. Thank you so much, girl. The thymus gland. Right? What's the purpose of the thymus gland? Hannah, since you've answered. Hannah, are you there? Maturation lang, girl. Sa bone marrow pa rin. Doon sila nagmamature. So you get thymocytes in your bone marrow, and they go to the they go to the thymus gland to be mature T cells. All right, but that's again a wonderful answer. The thymus gland, and the reason why it's called a T cell because it matures on the thymus gland. The B cell matures at the bone marrow. All right, all right, okay. Let's move on. What are the unfavorable prognostic markers? What are the unfavorable prognostic markers? Do we need to know this? Of course, some of it is important for you guys. So WBC count, I think the thing that you need to remember is these three. Why? Because they will appear time and time again. These are the most common markers of poor prognosis. Unfavorable, poor prognosis, this is the same thing. I'll put a star on it or an asterisk on it. What's 922? That is the Philadelphia chromosome. Is it a good prognostic marker? No. But in cases of patients with CML, it is a good prognostic marker because it means that the cells have not developed from CML, the leukemia of the patient has not developed ALL. All right? CML can actually develop into a secondary form of leukemia. It can either transform into secondary CML with secondary ALL, secondary AML. And the Philadelphia chromosome is an important marker for that one. Why? Because if it's found only in patients with CML, then that means that the patient has the capacity to survive chemotherapy. However, for patients with the Philadelphia chromosome that has been diagnosed with ALL, it means that there is another under that ALL is only a secondary finding to another insidious malignancy, which is usually CML. All right, so please don't forget that one. A lot of students confuse the Philadelphia chromosome with CML only, but it's actually found in patients with either with ALL as well. But it is used as a prognostic marker. All right. Another one is that patients who have acute lymphocytic lymphoblastic leukemia would have more than 100,000, not more than 10,000. I think that's 10,000. I think I was a little sleepy when I was typing this, so I'm going to change that one into 100,000. Okay, so that's 100,000. I got a little bit sleepy when I was preparing this, I suppose. And I forgot the extra zero. Terribly sorry, guys. All right, Philadelphia chromosome. All right, true or false? The Philadelphia chromosome can also be found in other forms of leukemia. Yes, it's found in the CML. If found in the AL, if found in ALL, it means that it's not a good prognostic marker. The patient may or may not survive. The patient would most likely not survive chemotherapy. All right. Another name for translocation 411. Another name for translocation 411. Does anybody know? This is actually a fusion gene. This is ML, not not ML as in Mobile Legends, MLA4 fusion gene. What happens is that in this particular case, imagine this is your chromosome. This is a normal chromosome. All right. Translocation 421. For example, here is the one that is translocated. Location 4 will be translocated to chromosome chromosome 4 will be translocated to chromosome 11, and it will form this fusion gene. All right. Well, how does this happen? It happens congenitally. Okay, so before you are born, you already have it. Actually, patients who have a history of leukemia in their family can get themselves tested for fusion genes, especially those who have family history of Down syndrome in their with their relatives. All right, so let's go with patients with the poor prognosis. Off to go to what form of treatment? So what form of treatment do people with poor prognosis opt for? They can't go for chemotherapy because they might not survive. So what's the next best form of treatment, do you think? It's actually been discovered in quite recently. I think in around 2005 was the first one that they did this type of treatment. Anybody knows what other form of treatment that can be done for patients with leukemia, especially those who have poor prognosis? Anybody? Bone marrow transplant. Very good. Somebody answered correctly. Thank you, John Mediana. Correct answer is bone marrow transplant. Very good. Very good. Bone marrow. Why? Because we want to. How do people do bone marrow transplants anyway? Um, in I think in the first time they did it was in Harvard University. I'm not familiar with the history, but they did it somewhere in the Western country. In Western countries, that's the first time they did bone marrow transplant. What they usually do with patients who get um what do you call this? Transplanted with bone marrow is that of course the first step is finding a match, of course. After finding a match, they need to check if the cells would survive course, the reason why we need to cross match is because we want to know if if the cells would survive in the host's body. Correct? After that one, all right, the patient is repaired. We need to kill off all the erythropoietic stem cells in the patient's body, and therefore the patient will be irradiated. Okay? So I will draw a radiation sign here, a radiation hazard. So the patient would be fully irradiated to kill all of the erythropoietic stem cells. After that one, transplantation will begin. Okay? Specifically, what is transplanted is the bone marrow stem cells so that they would produce new cells in the body. All right? Now, classifications of FAB. I think everybody knows this already. There is 1, 2, 3. I've already discussed 1, 2, 3. 1, 2, 3. All right. FAB starts as the size is small, 2 is large, 3 is also known as the Burkitt cell. Burkitt cell. Burkitt's lymphoma. Burkitt's leukemia. Another name for this one. Now, what is the cell distribution? It is homogeneous for FAB1. It's heterogeneous for FAB2. It is also heterogeneous for FAB3, but with the presence of Burkitt cells. All right. Now, the most commonly affected is children for FAB1. FAB2 commonly affected is adults, and for Burkitt cell is it's less than 2% of the cases. All right. Now, morphological appearance. What did I say earlier about the morphological appearance of a Burkitt cell? Can anybody still remember? I will call someone. Ella Villamayor. Ella, are you here? Are you with us? Or it's just your phone? Ella. All right, I will draw it for you earlier. We discussed it earlier. This is your lymphocyte. All right. What is present surrounding it? Can anybody know what's the difference between Burkitt cell from other forms of what would differentiate a progenitor Burkitt cell from others? I'm drawing it for you. This is your lymphocytic progenitor cell that is present in FAB3. All right. So what separates it? What's different? Anybody know? No, not the ALSA. Somebody answered already. The correct answer is yes, Renaline. Hello, Renaline. I haven't heard your voice. Can you say hi to me? Renaline. Sir, sira po mic ko. All right. Whatever. No problems. All right. This is your Burkitt cells. Lymphoblasts with noticeable vacuoles. Okay? That's the difference between Burkitt cells and the other forms of AFAB. Although they are large, they are vacuolated. When you look at it, let me use my highlighter, my laser pointer. Look at the vacuoles. Can you guys see the vacuoles? Right? It's like styrofoam. All right? It's like styrofoam. It's like when you try to scratch the styrofoam against a rough surface. The small ones that fall out is actually the vacuoles. So it's quite a sight to see. And inside this particular one, look at it. Look at it. There is nucleoli, which means this thing is actually multiplying. Okay? So that's your Burkitt's lymphoma. All right. Now that we're finished with lymphoblastic leukemia, we're going to go on ahead and continue on with acute myelogenous leukemia. And I think a lot of questions will arise from acute myelogenous leukemia. So I would say I will put a star here. And I don't want you to go to the exam on exam day. I don't want you guys to go into exam day without a little bit of knowledge about acute myelogenous leukemia, because I would be really disappointed if you weren't able to understand or answer some of the questions associated with this particular chapter, because there is a lot of questions that may be had here. Okay, and the potential for at least increase your grades. So acute myelogenous leukemia, put it on your to-do list. I want to memorize eight, all eight FAB classifications of myelogenous leukemia. All right. So what are the other leukemia forms? What are the true or false? Other forms of leukemia may lead to AML. True or false? That is true. AML can arise from CML. So as I mentioned earlier, as a secondary condition. Okay, I mentioned that one already earlier. Secondary AML can arise from what other type of disorders? It can arise from myelodysplasic syndrome, all right? MDS, Miriam Defensor Santiago, all right? Acute, aplastic anemia and myeloproliferative disorders, okay? Myeloproliferative disorders. As I mentioned before, one of the myeloproliferative disorders that we're talking about is CML, okay? So AML can arise from MDS, okay, Miriam Defensor Santiago, and the aplastic anemia. All right. So genetic abnormalities that can lead to AML. Well, you have Down syndrome, we have Turner syndrome, and Klinefelter syndrome. But the most important thing that you guys need to remember is Down syndrome, trisomy 21. All right, trisomy 21. Turner and Klinefelter syndrome. So we are going to discuss this is a basic summary of the AML classifications. So we're going to start with M0. All right. So summarize the cytochemical differentiation of all AML and AML. So that's one for late. That's the one for later. Need you guys to remember M2. I want you guys to remember this one. I will ask this before the end of our discussion. M2 is the most common form of AML. All right. So we're going to start one by one. Leukemia with minimally or poorly differentiated. This could also be poorly differentiated myeloblasts. Okay. M1 is myeloblast without maturation. So this one is differentiated clearly. The cells are clearly differentiated. While this one is a little bit confusing. Myeloblasts are present, but they are not, or they are poorly differentiated. What do I mean by a poorly differentiated cells? Because of being highly basophilic and it resembles a lot of other precursor cells, it may sometimes be confused with uh, lymphoblastic precursors. So one way to avoid that one is one way to correct that one, or rather to do a differential diagnosis, is to do TDT testing. That's the reason why it's important for you guys to remember TDT testing. Why? Because these two are poorly differentiated. We can't see the granules. There's no difference between them. Both of them have basophilic cytoplasm and nucleus. We do TDT testing to differentiate ALL from AML. All right? And this one, leukemia without maturation, is that there is no other cells present. Okay? There's no other cells present. So it's just myeloblastic leukemia, and most of the cancer cells that you will see in the bone marrow and the peripheral blood smear are myeloblasts. All right? Myeloblast with maturation, you can see other or scanty. Around 10% of the cells that you might count would be other mature forms, while roughly around 90 to 80 to 90% of the things that you will see in the blood smear, or the cells that you see in the blood smear, are still myeloblast. Hence the term with maturation. Okay? Are you guys still following? Are you guys still following? Huh? Cool. All right. Now, M3 is acute promyelocytic leukemia. Acute promyelocytic leukemia. Okay? Acute promyelocytic leukemia, this is your second stage of the blood cell, of the leukopoiesis. Third stage, the fourth stage would be M4, which is myelomonocytic. We're talking about now the monocytic precursors. So it's an abnormality in the monocytes. These two are more on the monocytic. All right. This M6 is the erythroleukemia or erythremic leukemia. What's the difference between this one? Is that the erythroid precursor is much more predominant. Erythroid precursors. So the cells that you will see that are undergoing, that are present in the cells would be erythroblasts, all right? Erythro erythropoietic cells. So what's the stages of erythropoiesis? I will ask someone from the chat box. Wait, let me check. Who wants to know? Who can answer me? What is the stages of development of RBCs? In order, I'll ask someone from out of the 50 people, out of the 49 people in this group. Um, Nobody wants to volunteer? Let's try Jerisa Baltazar. Jerisa, are you here? Hey, Jerisa. Hi, Jerisa. Do you still remember your erythropoiesis? What is the youngest cell in the last week's discussion? What is the youngest cell in the RBC maturation series? All right. Is that correct? Can somebody help her out? Somebody said erythroblasts. All right. Okay, so remember what do you call this? We have three nomenclature forms. So you're using the erythroblastic nomenclature. We have the normal blastic nomenclature and the other one. All right. So there's two. So you're using the erythroblastic nomenclature. All right. Ella, since you're answering, type or say the RBC maturation series right now. You can type it for everybody here, and we're gonna continue. All right, Ella, ha? That's your assignment. Continue. You started with erythroblast. Now type the remaining cells in the RBC maturation series. Because for M7, we're going to talk about the megakaryocytic. And actually, the rarest form is M7. The most common is M12, M2. Okay? So please don't forget this. This is important. All right. All right. She's using the erythroblastic nomenclature. All right. All right. I'm waiting. Demanding. Ang demanding ko ba? Sorry naman. Polychromatophilic erythrocyte. One, two, three. One, two, three, four, five. What's the last one? Erythrocyte. All right, she's completed. She's completed it. Congratulations. Thank you so much. That is a review of this one. That's the reason why we always discuss erythropoiesis before we study leukemias and anemias. Because you guys need to remember, you guys need to start with the basics first, the normal ones, and then we're going to move on with the abnormal ones. All right. Now, cytochemical differentiation of AML, also including ALL. This is our, do I need to remember this? Of course. Especially which one, sir? Um, uh, Noticeable ones. Diagnosis of M0 is done. I think everybody has the same myeloperoxidase and Sudan black B. I think everybody else from M0 to M5 would all the cells will test positive for these two states. Okay? M0 to M5 will test positive with these two stains. M6, because M6 is erythremic in nature, or erythroid by nature, it will only test positive for periodic acid shift. Huh, see? And M7 is neither a sorry, granulocyte or erythrocyte. It is therefore negative in both MPO, SBB, and periodic acid shift. Now, we're going to go one by one. Diagnosis is done if 3% of the cells are less than 3% of the cells is positive. Why? M0 has what? Poorly differentiated myeloblasts. Okay? So that's the time you will be able to diagnose it. Okay? Diagnosis is done if more than 3%. Sorry, I just put greater than percent. Sorry. We're going to edit that one. Another typographical error. I apologize for the typo. I apologize for typo, guys. So this is more than 3%. All right? More than 3%. Please put that in your notes when you get it. But I think I'm going to save this so you guys can have a copy of it that's corrected as well. Okay? Let's save this one. All right. PowerPoint presentation. All right. Next. Um, Pelger-Hewitt anomaly. What is Pelger-Hewitt anomaly? Um, Zyrene Alvarez. What's Pelger-Hewitt anomaly? Zyrene, are you there? Okay, so what's Pelger-Hewitt anomaly? Nobody. Oh, ignore ako ni ano, ni Zyrene. Inherited blood condition po. Yeah. Okay. Um. Okay. What's the appearance of the cell? That's my question. What's the appearance of a Pelger-Hewitt anomaly? I'll draw it for you. Peanut shape, yes, or what we call pin's nest. I'm drawing it for you, okay? Pin's nest. A form of hyposegmentation that looks like pin's nest. All right, pin's nest. Okay. M3 is important because there might be clotting disorders. So it is actually the only one that you can see a complication with clotting disorder, specifically DIC. What is DIC? Anybody in the chat or um, voice message, by voice chat? What's DIC? Uh, all right, wonderful. Medyo naputol because nag-unahan sila, but I still accept that one. Okay. Disseminated intravascular coagulation. Thank you, Gina. Thank you, Anna. All right. What is NSP, NSE, and SPE? That is non-specific esterase and specific esterase. M4. M4. All right. Please remember the names. M4 is myelomonocytic. Okay. M5, promonocytic precursors are present. So it's going to be based on blood smear and bone marrow morphology. And erythroid precursors, M6, you already know that. And M7 will test positive for alpha naphthyl acetate esterase and negative reaction with naphthyl butyrate esterase. Okay? All right? So please remember this as because of the fact that it is more on the laboratory side rather than the clinical side. This one is more on the clinical side because we're trying to diagnose the cells. This one is much more important for us. All right. So this is a high yield one. Okay, so please don't go to the examination if you don't have any idea what are the names, what is the notable things that you need to remember. All right. So if you're going to if you're I think I'm the one who's going to make the exam, try to focus on this one because there's a lot of things that they ask you, and take note of the things that I encircled. I made drawings for you guys. Although I'm not sure if the drawings is a little bit understandable. But yeah, I'm trying my best for you guys because I love you that much. Anyway, what's the most common type of AML? I've already asked this earlier. It's already highlighted. Anybody can answer the chat? The most M2, M2. All right, M2, M2, M2. What is the chromosomal abnormality in M2? Chromosomal abnormality in M2 is 821. 821. M2 stands for myeloblastic leukemia with maturation. All right, myeloblastic leukemia with maturation. What genetic abnormality is present in patients with M3? This is your T1517, which is your promyelocytic leukemia. So see the difference. See the difference. There are translocations. Before, um, when I was studying in college, they didn't have this one because most of our books haven't been updated yet on par with with cytogenetic analysis. Nowadays, they're giving you guys this one, so I feel very bad for you guys because you have a lot of things to remember now. Before we were allowed to remember only the Philadelphia chromosome, the translocation in the Philadelphia chromosome. Now I think every FAB classification has this one now. Okay? So please be mindful of that one. Which coagulation disorder is associated with AML? Anybody? I just asked this a couple of minutes ago. Voice chat or chat? Very good. What do you mean by DIC again? Hannah, what do you mean by DIC? Very good. Now, somebody answered juvelhetosis. What is the juvelhetosis? What is the AML type associated with DIC? All right, wonderful. Promyelocytic leukemia. Okay, so please don't forget promyelocytic leukemia is associated with that DIC. It is a translocation between T57 and between chromosome 15 and 17. All right. Okay, gingival hyperplasia is associated with patients with M5. A good way for you guys to remember this is that there is 5 letters in the mouth. Where is your gingiva? It is in your mouth. Not vagina, guys, gingiva. All right? So the mouth has 5 letters. Okay? 5 letters. M5 is the fifth one in the FIB classification. Gingival hyperplasia. So when the case starts like this, with patient was sent to the ER with gingival hyperplasia. Blood smear has blast cells present. Uh, myeloid precursors are present in the peripheral blood smear. Upon CBC examination, the WBC count is around 59,000. Positive for stains such as periodic acid shift, myeloperoxidase. Now, what is the diagnosis? What would be the probable diagnosis? That's how they would present these kinds of cases for you guys. So it's easier for you guys to say, at least think a little bit about some of the clinical findings. Okay? Variants of M5. We have M5A, M5B, and it's easy for you guys to remember this one because M5 is the opposite of M5A is just the opposite of M5B. It's just a matter of the presence of precursor cells. So granulocyte precursors would be greater than I would be less than 20 and greater than 80 for M5A, but for M5B it would be the opposite. So what I usually teach the students is just memorize one, and then the other one just remember that the other one is the opposite. Okay? So guys, so you guys have a lot of things for you guys in stock. Now, M5A. M5. What is another term for that one? Another name for that one is Schilling's leukemia. Immunologic markers that can be demonstrated for M5. We have C11B and CD11B and CD16. Right? Another name for M6 is Diguglemus leukemia or Diguglemus syndrome. Diguglielmo, Digugliel, right? L. Okay. Which type of leukemia can be treated with vitamin A? There is. Yes, there is. There is M3. We can treat it with vitamin A. So please don't forget that one. Do we need to know the treatments? Of course not. However, it might be presented in the exam, in an examination. So that's the reason why I love hematology. I no, not really. I don't love hematology because there's a lot of things to memorize as well as computations. But I love asking questions about hematology because there's a lot of things to ask and a lot of things to uh, juggle upon for the students. And a lot of the students are often confused, and I like confusing students. So please be mindful of the tips that I'm giving you guys. All right. What are poor prognostic markers for AML? Also, okay, that's the last one for our discussion of AML. So again, age 60 or above and greater than 100,000 WBC count, it is going to be a secondary. If it's a secondary condition to another bone marrow disorder such as myelodysplasia and CML, then that means the patient may or may not survive chemotherapy. What again is the treatment for patients who have poor prognosis? Somebody answered it already. What? Very good. What do you do with patients with bone marrow transplant? What is the first step in bone marrow transplantation? Cross matching. Cross matching what? Incomplete. Ella Villamayor, incomplete. Cross-matching what? Tissue compatibility or tissue cross-matching. Alright? The next step is irradiation. The next step is then transferring or transplantation of the what type of cells? Hematopoietic stem cells. Alright? So FL3 mutation is important. Huh? So bone marrow disorders. Alright. Let me erase this one because it's a little bit confusing. It's a little bit jarring. Oh, I clicked the highlighter. All right. So guys, do you still follow? It's too fast? Is it too fast? Do you guys still follow? Are you guys sleepy? What time is it in the Philippines? Oh, we still have one more, almost less than an hour. Don't worry, there's no extension today because I'm here with you guys all day, and I gave you already 1 hour, a 1 hour break, and I suppose that's enough. Um, I think this one would be the last uh, discussion that we're going to have for hematology. Uh, this slide, okay? So, um, before we continue on with chronic leukemias, I think the next one is chronic leukemias. Yeah. Before we continue on with chronic leukemias, I'm gonna give you guys 5-minute break, and we're gonna discuss chronic leukemias, which will be our last topic of today. And don't worry, I won't ask coagulation questions in your exam because it wasn't discussed in our seminar class. Is that fine with you guys? Or do you want coagulation questions? Wag na. It's too much na. It's too much na, no? Parang awa mo na, sir.